Do you think that like platforms like augmented reality, virtual reality, and mixed reality will allow surgeons to actually perform procedures from afar, like not telemedicine, but like telesurgery?
Yeah, so it's interesting question because I mean, conceptually, yeah, you could see that because you can walk someone through what they're seeing. You could see it. So I think assisted surgery, I think, would probably be the way to go because it still goes down to the articulations. That's a little bit more challenging. But if you look at like technology disruptions, I'm gonna go back to with robots. I think robots are here. I'm not questioning the robot. If you look at like how technology disrupts, it has to be a market that's underserved, has to be some challenge or difficulty to overcome, and it has to be cost efficient. And virtual reality or augmented reality is very cost efficient. It's in your PlayStation 4. So you look at market inefficiencies. $1 million robot can be very quickly replaced by a $5,000 augmented reality system. And so I do believe that most hospitals will make the $1 million acquisition, and they'll have that in the next 5 years. I think that's just inevitable. But I would just say that disruptive technology moves very quickly because price points are much lower. And augmented reality has already been being refined in different applications. Just a question to figure out its niche in spine surgery. I think I think it's a smaller stepping stone than we think.
I mean, my personal opinion is that like virtual reality will be more useful for like surgical training, where you're immersed in that, and just you saw the video that you showed of that surgeon trying to or that person trying to do a certain type of procedure, right, virtually. But I think augmented reality is something that we're going to be using in order to help us during the surgery itself. So do you have any thoughts on maybe what's any use of mixed reality where you use a little bit of a hybrid of both?
So I tried. I don't know if you guys used Google Glass. So they had Google Glass for us. There was one of our, actually, I don't know if Rick, do you remember Rashad? He was one of our neuromonitoring techs. He was developing a medical application for Google Glass, and then he actually left neuromonitoring. He had an application for an MRI. So you could see the MRI images, and you could, based upon your looking up, you could move and scan through the MRI images. So I had it. The problem was that you use loops and you go back and forth. And actually kind of interesting concept. So you could actually see. We used it for like a lumbar disc herniation. So you could actually see and scroll through and say, okay, I see the disc herniation is more paracentral. It didn't augment reality. It was additional information. But the next concept then is overlaying what you're seeing. And even if it's crude and it's rudimentary, it gives you some insight as opposed to the surgeon looking up, coming back, and changing it. So the fact that it's already there that can handle high enough resolution images. The question is refining the application. But I agree with you. Virtual reality is for transitioning and education. Augmented reality is actually for helping the surgeon refine their technique or improve or minimize the complication or to improve just even ergonomics or workflow through the operating room.
Minku, so is there a question back there? Go ahead. Sure. Absolutely. Absolutely.
One, when the power goes out, what happens for the next generation that has their initial training is on augmented systems? How do you safeguard fundamentals in training? That's one. And what do you know about neuromonitoring with like studies with phantom syndromes, like phantom-like syndromes, and for tactile feedback in robotics? Has there been any research with combining those technologies?
So there's a compound question, varying topics. I'll kind of break it down. The first thing is when the power goes out. I've never seen the power go out because we have backup generators. And if the power goes out, we're screwed for other things because you can't use a burr, you can't use a bovie, you can't use a microscope. So you're just screwed, right? So fortunately, most of us, we don't operate in environments like that. So the reality of a power going out is unusual. Two, augmented reality systems are self-powered. They're not powered by external devices because if they were, they'd become immobile or they'd become cumbersome in the operating room environment. That would not necessarily augment reality to be harnessed to something. So I think that's not the concern on that point. As far as the question regarding phantom limb monitoring, you can't monitor phantom limbs. I don't know how to monitor that. Phantom limb dysesthesia is definitely a known medical concept, but I don't necessarily know the treatment of that. And I don't think that's an avenue of spine surgery per se.
I guess what I'm saying is that now they have neuromonitoring to activate robotics, right? So like I put
Oh, so you're talking about a little bit something different. You're talking about neuromodulation. You're talking about thinking like, so they can use prosthetics, right? So absolutely.
Exactly. So if you take that concept and combine it with more tactile feedback in robotics, actually stimulating your nerves in your hands based on what the robot's touching.
I mean, theoretically, you can try and attempt to do anything. It becomes a cost efficiency or cost point for integration. And the simplest thing for the surgeon, if you really look at, for most surgeons and what they really do, whether it be a general surgeon, a spine surgeon, neurosurgeon, orthopedic surgeon, whatever it may be, your fingertip, your index finger is probably the most important thing that you do. You dissect, you feel psoas, you feel the anterior portion, you may sweep off scar tissue. Everything you do is based upon the index. So, a large portion of it. I mean, grip strength has some other issues, but that can be simulated, and that's probably the easiest starting point. It becomes cost prohibitive to kind of capture the entire gamut of options, but your fingertip is probably the essential thing to start with.
Dr. Kim, do you have a comment or question?
I have one comment and one question about the SI joint fusion. My comments is that about the diagnosis of SI joint pain. There are recent interesting paper based on the randomized controlled trial by the pain doctors between the intra-articular injection and the injection over the SI joint capsule. So they conclude that the injection over the SI joint capsule is better than the joint intra-articular injection. So I changed my policy when I want to diagnose SI joint pain, just injection over the SI joint capsule. So I'd like to recommend the injection tools for you. And the question is that if you have any failure case after SI joint fusion, is there any strategy to revision or removal?
So first I'll start with a rebuttal for your first. So that paper does talk about capsular injections versus intra-articular, and probably about 80% of SI joint pain is improved by a capsular injection. There's about 20% that actually, though, comes from the anterior ligamentous complex, which you can't really block. You can block the posterior, for example, with an L5 through S3 lateral branch blocks. So that paper is probably covering a majority of patients, but not all patients. So just as a caveat to that. The second question is, what are the revision strategies? And so this is an MIS course, so I'll start with the MIS revision strategies, which are now more robust than they used to be. The implants that I use are equivalent to a 7.5 millimeter diameter screw. However, they have new ones that are much larger with an osteotome set that comes in that fits right over the implant, where you can break up 2 of the surfaces. In case, now the question is, why are you revising? If you're revising for pseudoarthrosis, it shouldn't be too hard to pull one out because it's pseudoarthrosed. That being said, most of the revisions have not found that to be the case. What they found is that the implant had gone too far into the foramen. And for that sort of revision, the biggest issue is when you place it. And when you place it, if you're right on the foramen, especially if you're towards the top third, because that's probably where the nerve root is, you're more likely to have it. And it's really hard to move one of these after 6 weeks when they're not pseudoarthrosis. You have to chisel it out. So I know at least one of the companies has a revision tool set that has an osteotome slide that allows you to break up right around the implant and place a 9.75 millimeter implant, which is equivalent to a 12 millimeter screw. So that's the ones I've revised have all been open. I haven't done that MIS strategy myself yet because I think it's just become available. Open, I've always just gone posterior. And what I've done is open up right over the PSIS, decorticate the PSIS, then, bite it off with a Lexel, decorticate the SI joint posteriorly in that ligamentous complex and pack bone in there. Now, the downside to that is I don't know really the post-operative guidelines with that. So I've been very conservative, and I've used 6 weeks toe touch weight bearing. And so that, from my perspective, was a very morbid. I've only done it once in one of my patients and 4 times in other patients that have come in. So we're talking about an N of 5. I don't want to make it seem like I've done, tens or 20 or hundreds of these. But I found the open posterior strategy has worked in all of those patients. And it's really about decorticating that posterior ligamentous complex to have a bony interface in which to pack bone into. However, with the new MIS strategies, I would use those first, which is remove the implants and put in larger implants.
Sheeraz, I have a question for you, sort of an extension of what Kern mentioned in his discussion, which are valid points, meaning that these systems tend to be very expensive, so cost prohibitive. And then the second thing is, a company like Mazor has been working on this for 12 plus years now, and it still boils down to actually a guide for placing in pedicle screws, right? So based on your knowledge, how would you answer those two questions, the cost price point question, as well as what would you advise these companies as far as, pedicle screw placement instrumentation is one thing. What would you recommend with respect to how they should actually sort of evolve next? Should it be decompression? Should it be fusion? How should they go about?
So I think that those are important points, right? I mean, everything that we do, we have to be cost conscious. I think as surgeons, hospital administrators, companies, we're all going to have to come together to figure out a way that we can continue to do things better, prove that they are better, and that they're adding a value. And then, any of these things, just like with surgical procedures, if you are looking at 1 year cost effectiveness value equation, it's not going to be cost effective, right? I mean, an epidural at 2 months is going to be more cost effective than spine surgery. But for that same pathology, if you look at 5 years, all of a sudden the surgery becomes more cost effective. So the same thing goes with a sunk cost like a robot. So I think what Kern says is an important point. You have to make sure that your technology is not going to be quickly replaced and that it is going to be something that's going to help you. I think the second point, though, is even more important, that right now, a product like Mazor, for example, which is really just a guide wire assistant, is not cost effective. It's probably going to be cost prohibitive. So my involvement with some of these companies, which is very cursory right now, but the end effectors now are changing, and it's more about planning your entire procedure, and not just procedures where you are doing a fusion or using instrumentation, but procedures that you are doing decompressions, discectomies, so that you're not missing a fragment, so that, if you're doing a bilateral decompression, that you're getting out the opposite side consistently. If you're doing a deformity surgery and you want to do an osteotomy, that you can plan out your osteotomy cuts and get exactly the type of correction that you want. So those are the things that I think are the next step, and they're not as far as we think. And I think that adding that value across surgery is going to obviously just add value to having a robot.
Do you believe that at some point that the robot will be able to do the entire surgery from skin to skin? And then if so, how many years?
So do I think the robot will? I don't think the robot will, but do I think that we can set trajectories and the robot can be a participant to guide the surgeon to be more accurate and predictable, so that if we say we want to get this area of disc out and we want to put our inner body implant in this exact spot to get a fusion, right? I mean, when you think about MIS TLIF, simple thing, right? Why do we still sometimes get pseudoarthrosis? Well, maybe we're not preparing the end plate in the same place that we're inserting the inner body cage every single time predictably, because we can't really look inside. But if a robot can make that process more predictable, that we're going to prep the end plate, place our bone graft, place our cage exactly where the fusion is going to take place, that is something I think that from start to finish, I would say that the next generation of robots is going to be able to be a participant in surgery from the time you cut skin to the time that you finish, not just putting in guide wires. I think that's very close.
Got it. Rick?
When I look at the adoption,
There we go.
when I look at the adoption,
of the microscope and the adoption of posterior instrumentation for spinal surgery, the adoption of minimally invasive surgery, and the adoption of even image guidance, it's always at least a generation and a half. So you really think it's realistic to say we're going to be adopting this in 5 years?
I mean, my only sort of point about this is like, they said this exact same things about the automotive industry. They said there's no way it's going to be possible that you're going to get rid of all these people on the manufacturing plant floor, but it happened. And the reason why that is because like robots can do things that humans simply can't do. I mean, they have a degree of freedom that we simply don't have.
I don't disagree with that, that eventually this is going to happen. But I think the timeline is much longer than you suggest.
That's true, and I don't know, but what I'm saying, the rapid pace of technological innovation, we're so far behind in medicine, it's true, in healthcare. We tend not to actually utilize the technology that's freely available to us, because it's there right now, and other industries are freely using it. And that's the reason why like robotics and AR and VR, we're late adopters here.
Well, it's also, I mean, I think you make a very valid point amongst spine surgeons, but I mean, robotics in other areas of medicine is already well accepted and adopted. So I think that may change things. Now, whether it's 5 years or 15 years or even 50 years, it's hard to say, but I think the trajectory, I think, is towards adoption.
It's funny. I
also add, Rick, I agree with you, but I would add that I would say millennials, younger generation or whatever, younger than me, so I'm 41, around the same age, they're more willing to adapt and adopt new technology at a faster rate. I think exposed to change faster, and they're more willing to accept and adopt it. That's my sense. So I do agree with you, there's some kind of generational blindness, so you look back like you forget so you can kind of move forward. I just think that they are more willing to tolerate change and kind of fluctuation, I think more so.
But I don't think that's any different than it's ever been. I think my generation was more willing to adopt the new technologies as they became available than my teachers, and I think the guys I'm teaching now are more willing to adopt new technologies than I am, but it still always turns out to be that generation and a half, because you got to get rid of us old farts.
I think one thing that Kern said is very important is anytime a technology disrupts an industry, it's got to fill a need. Now, the problem that we currently have with robotics and with AR and VR is live recalibration of what's going on. You can superimpose what happened in the past, like an old CT, an old MRI, but as soon as you open, it's all changed. So that's why, Mazer's kind of been limited to, before you do anything, you can put in guide wires. So I think that's the fundamental need that's a problem. If you look at the Da Vinci robot, how many hospitals have Da Vinci robots sitting in the corner? And that was supposed to change general surgery 10 years ago. And so there's a generational thing, but it's got to, a microscope made sense. You can visualize, you had better lighting, right? So you didn't have to have your neck like this, so you needed an ACD in 10 years. So I think it got adopted in a much more rapid fashion, and that was a generation and a half, but it filled a need that people didn't know they had. The problem with robotics currently is they fill a technological need, but they don't make it any faster or safer from my standpoint, because as soon as I open a head or a spine, the anatomy's changed. And unless I recalibrate what I'm looking at, so AR is great, from that standpoint, if you're getting live updates on your baseline imaging, and you're not. And if you do, the whole reason you're doing it is to save fluoroscopy or save radiation. Well, you got to radiate, or you got to have an intraop MRI and different tools and change your workflows. I think that's actually the biggest barrier than the technology itself. I mean, it's in a lot of other industries. There's a reason that we're not walking around with Google Glass. I mean, how many years did that come out? That was supposed to disrupt the industry, right? And so it didn't fill a need in the end. And I think that's where robotics is missing the ball on, is what need are they filling? Are they making surgery safer? Are they helping us correct a deformity better? Are they reducing CSF leaks? And the answer to all of that is no yet so far. And until they can do that, I mean, generations aren't going to adopt them. Well, younger people may say, I'm willing to try it, but you're not going to get widespread adoption.
It's interesting because we as spine surgeons, and that is so true. Like for some reason, as spine surgeons, neurosurgeons, orthopedic spine surgeons, we're so far behind the curve. It's unbelievable, right? Like
Well,
we.
I disagree with that. You talk about doctors or surgeons as if they're idiots. I mean, medicine's based on precedents, so it's like law. It's big emphasis on safety. So, I think the public respects that we don't jump into everything new. And so when you say, well, we're behind, all true, but it's just based on the inherent, sense of you do what your professor did, or, because it's safe and there's precedent. So, I mean, I think there's a natural bias of doctors not to innovate because of our training.
But how about what you created, though, Bruce? That's a very innovative product, right? So the thing is, like, how do you try to get people to adopt that? Because it's such a different way of thinking about it then. Because you're sort of, that's counter to what you've actually done.
It's hard. It's hard to create change, but I think that's a good thing about medicine is that they're resistant to change because it's very safety conscious.
Mm-hmm. No, but,
So I guess one of the issues that we deal with, and I go back to Rick, so I'm going to challenge you on this one, Rick. I'm going to say one of the things that we have innately as physicians and spine surgeons is training bias or educational bias, how we're taught, how we perceive. And the second thing that we have is we have a market dominated by the same players who are implant manufacturers, and it's harder to monetize others. I'll go back to AR and VR. It's hard to monetize that. You can do it off licensing arrangements, a software arrangement, small capital purchasing. So you have different players who are trying to enter into the space who don't necessarily have the brain power, the trust of that particular area. Except now, I'm going to challenge it that Google is coming in, and Google and J&J are coming in. And I go back to Verb Surgical. They are about to release a robot second quarter 2018 at a cost, I said, of $50,000 to replace all the things, everything else is out there.
That's crazy.
So that is medically disruptive. You give me a $50,000 robot, there's no reason not to have that, and we can incorporate that. But the archaic, it's a monopoly in some sense by the current manufacturers and how they monetize products and their penetration that limits kind of newer technologies coming into play. I think, though, Google is powerful enough to change that. Now, that maybe in spine surgery, in some aspect, we may be slower to adopt that, but I think that there is an innovative force that's coming down this pipeline very quickly.
Well, that was a very stimulating conversation. Let's give these panelists a round of applause.